Problem solving. iGel is easier to use than many other supraglottic airways, so problems should rarely be experienced, providing the user has read both the instructions for use and the iGel user guide. Good airway management practice should always be followed. However, it is prudent to consider the most appropriate action to take in the unlikely event that the device is not performing as expected. Most problems can be avoided by ensuring a few basic principles are always adhered to. Ensure the correct size of iGel is used according to the patient's weight. A good patient position is adopted prior to insertion. The device is adequately lubricated on both the front and back as well as the sides. The lubrication to the sides and front of the device cuff is particularly important and should always be adopted. These simple actions will help to significantly reduce the possibility of problems occurring. Incorrect position. A horizontal line at the middle of the integral bite block represents the correct position of the teeth. If the teeth are located lower than the distal tip of the bite block, then it is likely the device has been incompletely inserted. In this instance, remove the iGel and reinsert with a gentle jaw thrust applied by an assistant, or a triple maneuver with mouth opening, head extension and jaw thrust, or a deep rotation, in which the iGel is rotated slightly to aid its passage through the fascial pillars before being restored to a normal orientation for completion of insertion. If that does not resolve the problem, use an iGel that is one size smaller. Coughing and breath holding. Prior to the insertion of iGel, the following indicators should be used to confirm an optimum level of anesthesia has been obtained. Loss of eyelash reflex, loss of response to jaw thrust, loosening up of the jaw, for example, being able to move the chin up and down easily without resistance. Using these simple checks should help to reduce the possibility of the patient coughing or breath holding during insertion. However, if the patient does start coughing or breath holding, then anesthesia must be deepened by an intravenous injection of an agent like propofol or with an inhalational anesthetic agent such as sevoflurane. If the patient is being paralyzed and ventilated, then the adequacy of the muscle relaxation must also be checked with a nerve stimulator. Should a patient show signs of gagging or coughing during the recovery phase, remove the iGel and adequately suction the pharynx. Air leakage through the gastric channel. A small air leak, air venting, through the gastric channel may be a useful mechanism to protect against gastric insufflation. But an excessive leak means the device is probably not seated properly, and that the airway and gastric channels are not isolated from each other. In such instances, remove the device and reinsert with a gentle jaw thrust applied by an assistant, a triple maneuver, or a deep rotation. Inadequate seal pressure. Seal pressures with iGel are generally excellent and should be more than enough for both spontaneous and mechanical ventilation. In the unlikely event that seal pressure is inadequate, it is advised to use a larger size than is recommended on a weight basis. However, even if the seal pressure in a given patient would allow it, peak airway pressure of ventilation must not exceed 40 centimeters of water in order to prevent barotrauma. Excessive air leak. If an excessive air leak during IPPV is noticed, use one or all of the following. Hand ventilate the patient with gentle and slow squeezing of the reservoir bag. Limit tidal volume to no more than 5 milliliters per kilogram. Limit the peak airway pressure to 15 to 20 centimeters of water. Assess the depth of anesthesia and muscle relaxation. If all of these fail, then change to an iGel that is one size larger.